is not the fucking. Oh. Ah. Hey, how you doing?
Fine, thank you.
So you guys use a webcam, right?
Yeah, we do.
That's a webcam and a laptop. That's it, right?
Yeah, that's it.
Okay, I'm getting. Some feedback. Yeah, I want to ask you something when you get time.
Yeah, wait.
بتفجرها يعني والله في دكتور تسأله أعطيني كارت عيادة
Start in a few minutes. I guess we're live now. I don't know if you guys have seen Dr. Sabea's multidisciplinary, but he frequently has at least a pathologist, sometimes a radiologist. Should look smiley, waiting for this to start. Actually, we could have an intro act. See, Hospital Infantile has a live presentation.
Hello. هلا مساء الخير.
Okay, Assalamu alaikum, مساء الخير. Good evening. My name is Ibrahim Sbeih. I'm a neurosurgeon, and we are transmitting live to our international audience from the Farah Medical Campus in Amman, Jordan. The topic for tonight will be about Hydatid disease, and we'll concentrate on the central nervous system affection. Hydatid disease is rare in developed countries, but it is a considerable health problem in endemic areas. And when we say endemic, in Asia, Middle East, Arab countries, Turkey, Europe, Eastern Europe, Australia, New Zealand, Latin America, because of the sheep and cows there. So in the Mediterranean, Turkey, Greece, Spain, France, Italy. In the Middle East, Syria, Palestine, Lebanon, Jordan, Gulf area, Egypt, and Libya. Latin America, Argentina, Uruguay, and Paraguay. So this is the universal burden of the Hydatid disease. The dark color means that it is highly endemic. The lighter is endemic. The white is almost does not exist. The reason is the slaughtering in the slaughterhouse. This is what should be done to keep the clean atmosphere for these things. But in the Arab countries in the Middle East, especially in the Eid of Sacrifice, Eid al-Adha, livestock is slaughtered without any supervision in the streets. And this drives me crazy every year, trying to change this concept. And it is pity that children and young adults are the ones who are affected. That's because of stray dogs, because of the farming, livestock, and poor sanitary regulations. Forgive me for the images that I'm gonna see. This is reality. Each and every one of you see this in our streets, in the streets of Pakistan, in Turkey, in Yemen, and the Middle East in general. People slaughtered in the street, and they are proud of it, in the name of religion. This is a true picture from Egypt. Look at this, blood and everything in the streets. Look at this picture. And this is from Amman, Jordan, in the Eid. Celebrating the Eid, we slaughtered in the streets. And what kills me, that municipality of Amman announces in the newspapers, on TV, that places for slaughtering on so-and-so street, on so-and-so corner, which is very criminal, to say the least. I'm not going to dwell on the life cycle. I'll leave that to Dr. Muntasar Bibisi. But basically, once Dr. Muntasar tells you the life cycle, and once it gets to the human, it takes time to grow. It grows by 1 to 2 centimeters per year. And these are some of the Hydatid cells that I removed. Some of them, they can grow faster. This grew in 9 months from this size to this size. The main thing to remember is that this cyst is in the brain or in the liver. So this is the host area, his host capsule. And then we have the laminated area and the germinal layer. So 3 layers. Again, We will elaborate on this with Dr. Hussam Al-Farzakh. So the global burden of Hydatid disease is very, very heavy. In China, where it is endemic, in this period, 96 to 2010, 58 hospitals, they treated 21,000 more, and 45 patients, they had brain Hydatid. Again, the burden lies on the children. In France, a developed country, in the period between 82 and 2007, they treated 387 patients. So whether you are underdeveloped or developed, you will get the disease if you're not careful. Muntasar, can you give us an idea about the epidemiology?
Thank you, dear Dr. Ibrahim. Good evening, everybody. It is unfortunate that we still have to see these cases, and the suffering of these patients is very real, as I'll try to show some illustrative cases. This is caused by a parasite called Echinococcus granulosus. It's one of 4, but the most common worldwide is Echinococcus granulosus. Endemic areas, pretty much wherever sheep are reared for human consumption: South America, Eastern Europe, and Turkey and Greece, the Mediterranean basin, Australia, and New Zealand. If I can just elaborate a little bit on the life cycle. So we'll see if we can do it this way. Dogs consuming raw sheep leftovers from slaughtering get the infective stage. It develops in their gut, grows into an adult, and releases an embryonated egg consumed by man or child or by sheep. So this could be a dog that had some poop, excuse my language, on the grass, on strawberry, on lettuce, ground vegetables. And then someone consumes them without washing them properly, and in it goes into the gut. It crosses over to the portal circulation and establishes itself in the liver typically. Or it can be disseminated more to the lungs and other places, including the brain, the bones, spleen, kidney, and so on. So dogs get it from eating leftovers of sheep. What dear Dr. Sbeh had shown us in these abattoirs, in these makeshift slaughterhouses, that we see in every Eid. Absolutely no control. So you throw one of those things, and in countries that have tried to control this disease, they look for animals that have the disease, and they either incinerate these, for example, the liver and whatever, spleen, or they freeze it to -18 to kill the portoscolices, and then they throw them in landfills. If we feed one of those to the dog, stray dogs are going to transmit this across, and children are the most vulnerable.
Dr. Muntasir,
Yes, sir.
but it seems that the dogs are the ones that transmit it to human beings,
Correct.
not the sheep.
Correct. That's what I said. So dogs get it from the sheep, and dogs spread it to the sheep and to humans. Inadvertently, because dogs are man's best friend. Dogs are very close to us. Dogs can poop on the beach. Dogs can poop in the prairies. Can poop on vegetables, ground vegetables especially, and then we consume and we get the disease. Clinical manifestations may range from an incidental finding by our dear radiologists, or to space-occupying lesion with mass effects, such as on the portal vein or intrahepatic biliary ducts causing jaundice. It is found in the liver most commonly, alone in 75% of cases, and in 25% of cases, liver and another locality. Lungs, heart, mediastinal, pleural, pericardial, and then brain, kidney, muscle, bone, and spleen. They may manifest as by rupture or leak, causing an anaphylactic reaction. They may get secondarily infected with bacteria and come in with fever and abscess-like picture, or they may hemorrhage. And I'll quickly run you through some illustrative cases from my own practice. Case number 1 was that of a 24-year-old male that came in with vague abdominal pain. You could almost discern some discomfort or a bit of a tenderness in the right upper quadrant. And lo and behold, he had a huge cyst with some daughter cyst or movement of the actual capsule over here. You can see the capsule coming off. Went to surgery. During surgery, there was aspiration, injection of ethanol, and re-aspiration and re-injection until they got all the liquid out and were able to remove the capsule intact, as you can see. 29-year-old male mechanic with right upper quadrant pain, and you can see that this huge hepatic abscess, cyst, has ruptured, giving what is known as lily sign, water lily sign, with some hepatic hypertrophy. Of note, echinococal titers, and we'll talk about those. Number 1 I see in the audience was 1/1280. Case 3, a male gentleman from Saudi Arabia that arrived with dyspnea, and his chest X-ray, you can almost discern this extra shadow. And CT scan showed that cyst with calcification, and echo showed 2 cysts in the heart with calcification, compressing the left ventricle, and he went to surgery. So that's the case of cardiac echinococcus. This 64-year-old Iraqi male university professor was brought in by his apprehensive wife. Why? Because he had stopped breathing and collapsed 5 days ago on the street. This was not the first time around. He's had a similar attack 7 and 10 years ago. And so much so that she now carries an epinephrine pen with her. He didn't seem to care, but she was worried about a deeper problem. And lo and behold, he has these cysts in his liver, and we think he had probably a leak, a spontaneous leak that caused an anaphylactic shock. His titers were high, 2560, and his IgE levels were elevated, and there is support from the literature for such happenings. Went to surgery and has been doing well since then. I won't belabor all of that. Now, this is probably the saddest of all cases, being a 26-year-old female who had a road traffic accident in her school graduation, and was left crippled from the waist down. Struggled and got a bachelor's degree from a respectable university, and was seeking to get a master's degree. So came in for a physical, and her chest X-ray showed these huge cystic lesions in the lungs. She was treated. We opted not to take her to surgery because of the high risk. I believe it was one Friday morning that her frantic mom called me and said she had collapsed on the floor. They called 911, got her to the hospital, but unfortunately she suffered irreversible brain injury and died. When she came in, the most glaring finding was the absence of one of those cysts. So the cyst had ruptured and caused an anaphylactic shock, and she died. 56-year-old male with dysphasia came in with this brain lesion. And with brain lesions, we know about 20 to 30% there's a lesion elsewhere. And so he was scanned, and he had a hepatic lesion as well. As explained by Dr. Spray, brain lesions are rather rare, 1 to 2% of all cases, more in children, and they characteristically are, with serology, only 4% would be positive, and this patient was negative.
Is
the seeding at the same time?
Yes. Well, we don't know. I mean, the typical time to presentation is an average of 7 months, but maybe anything from 6 months to 3 years. They're supposed to grow by 1 to 2 centimeters a year.
So my question would be, is this just, I mean,
Yes.
the actual infection is both locations in the same?
Yes, sir. So these were obtained at the same clinical evaluation setting. Management, surgery for the longest time was the main tier of management and still is for these following indications: complicated cyst with rupture or fistula, or if it's compressing a vital organ, we want to get it out. If it has too many daughter vesicles and not suitable for repair, if the size is larger than 10 centimeters in diameter, a superficial cyst at risk of rupture, and extrahepatic disease in the lungs, bone, and brain. But I just showed you that clinical judgment must be practiced. We had a guy that had a leak. It's not in these indications, but that's medicine. You have to use your judgment, obviously. A contraindication would be for an inactive or calcified cyst. Now, PAIR is a modified. Yes, sir.
Why is extrahepatic disease an indication?
If it is compressing,
It's compressing about the structure now that I get as an indication. And you're putting number 5 as a sweeping rule that extrahepatic disease by itself is an indication, regardless of the compression of vital structure.
no.
I'm not understanding the line.
These are the informal advices and guidelines in textbooks, but as it happens clinically, we don't take that too strictly. We only go for surgery if it's compressing a vital organ that is making the patient present with symptoms of obstruction.
Or a chance of rupture.
Or a chance of rupture, absolutely, yes. So PAIR has been practiced for a while. It stands for percutaneous aspiration, injection, and reaspiration of a scolicidal agent. The idea is that we get some of the fluid full of infection, scolices, and inject alcohol or hypertonic saline to kill the other scolices in the fluid, such that when surgery is done and there's a spill, it doesn't cause daughter cysts, or we are trying to sterilize the cyst as such. Okay, by sterilize, killing a all potentially infectious agents.
Is that what causes basically your anaphylaxis? Are you also trying to control anaphylaxis, or is the fluid itself?
The fluid.
Daughter cells, or is it the actual disease, or is it the actual fluid that's causing anaphylaxis?
Supposedly, every daughter cyst contains anything from 10 to 100 scolices, the protoscolices, the infectious agent. And it's a tremendous storm of antigens that enters the system.
Just like septic shock.
Yes, sir.
Exactly. So if you kill it off or you do saline, you're basically controlling that issue.
You're trying to control for that because you get a storm of mast cell degranulation, and the shock part is very real.
So back to Dr. Marwan's question, it's the scolices that are the culprit, right?
Yeah, we want to kill those.
They're the antigenic.
They're the antigenic component, they're the infectious component as well. So if these leak into the intra-abdominal cavity, for example, you get daughter cysts. There is a WHO working group classification depending on the depending on the actual content of the cyst, defining an active cyst by these appearances and inactive by calcification. And I'll explain in a bit how we use that for treatment. So depending on which stage the patient has, by ultrasound, being the poor man's method of radiology, we can dole out the treatment, whether chemotherapy, albendazole alone, or with PAIR, or with surgery. I won't bore you with the details, but the medical therapy available to us these days is quite effective. It's albendazole, and we give anything from 1 to 6 months in adjunctive to surgery or PAIR. And it causes significantly less recurrence before or after surgery. So someone might be going to surgery, or give them albendazole pre-op to try and kill those colices. Or someone went to surgery, they found, oh my God, it's a Hydatid cyst, get it out, send them to ID, we give them albendazole. Praziquantel, despite this supposed lack of efficacy data, there are papers that recommend this both as pre-op prophylaxis. There's a paper from Pakistan that showed a lesser incidence of recurrence when we use praziquantel upfront in combination with albendazole. Okay. Yes. So praziquantel may be used. It's not the standard of therapy, but we have resorted to it in certain situations. Albendazole inhibits microtubular assembly and kills the germinal layer cell, showed to us earlier by Dr. Sbeih. It is poorly absorbed and must be taken with fatty meals. We observed for adverse events such as hepatotoxicity, cytopenias, nausea and vomiting. The outcome of albendazole treatment as evaluated by ultrasound, 30% cyst resolves, 30 to 50% there's reduction in size, and in 20 to 40% it stays the same by ultrasound. So
what is the penetration for the blood-brain barrier with these agents?
it's very good.
For all of them?
Praziquantel,
Albendazole, and
praziquantel less so. Albendazole is the most available in the central system. Praziquantel is what we used for schistosoma, for bilharzia.
And you get the same kind of results, statistical results in the brain.
Albendazole has better outcomes and is more reliable and is the standard, the gold standard of therapy. Praziquantel may be used if you can't find albendazole or if you want to use it in combination with albendazole. But the gold standard of medical therapy is albendazole. Used to be mebendazole, now albendazole is the standard. So parasite control, basically look at these, although they make sense, that, you know, for some reason they're not practiced in our country and in many other countries, including, you know, not to name names, Turkey, Greece, the Mediterranean basin. Before I came to see you guys, I was reading a paper from Algeria. So this is a common problem, and it is seems to be a problem of Muslim communities, but also Christian communities. But I know for us, you know,
it's a cultural thing, not a religious thing.
yes, it's a cultural thing. In the heydays of the old Wild West, of course, you slaughter your own kharoof and you're very happy about it, but that doesn't cut it anymore. It does not cut it anymore. It's a very dangerous practice to have the scenes shown to us by Dr. Sbeih. And it almost seems like there's an increased incidence lately of these. We're seeing more cases. And it does not surprise me one little bit. Where I live in Marj al-Hamam, you know, stray dogs are abound. And we call the authorities and they come and they don't come, and plenty of stray dogs. So the chance of having this disease and perpetuating its transmission is very real, and I think it's continuing in our country. Countries that have been able to eradicate this, such as New Zealand, have done a tremendous work. The veterinarians screen the sheep, and any sheep that's found to be infected is slaughtered, and then they decontaminate with either incinerating the whole sheep or using freezing to -18 degrees to kill the protoscolices, and then they throw them in landfills. And they're very, very strict about this. Something that I cannot imagine happen in our country.
That's to treat the animal life part of me. Humans are the problem, not God. Just to set the record straight. The real problem is humans, not the.
I think you can generalize that to pretty much everything. Humans are the problem.
I agree.
Poor animals have to pay the price of our indiscretions. Infection control concerns, there's no person-to-person transmission as you do the surgery. Of course, you have to properly dispose of the resected material, and for sure, don't feed it to the dog. So I guess that's where I'll stop.
Thank you.
I have a quick question.
Yes, sir.
Thank you, Dr. Sir. A couple of First, how often the albendazole sterilize that cyst? Essentially, I put a needle in there, aspirate all the spolios in there are there. That's the first question.
It depends on the duration of use.
So
We like to get at least 3 cycles in before you guys do something like that, if possible. And by 3 cycles, it's 4 weeks on and 2 weeks off of the medicine. If we complete that, it's a 90%, but it's not 100%.
I think that's very important. I think the duration, because we experience, as you know, we do the PER technique,
Yes.
a percutaneous technique, and on a couple of occasions in the liver, after 2 cycles, the patient got kind of mild anaphylaxis by just puncturing the cyst and aspirating before injection. So I totally feel you are 100% accurate. 2 cycles were not enough to actually sterilize that cyst.
Yes.
So that's from just a few cases that we did.
Absolutely. And even if we sterilize it, the chance of an anaphylactic shock is still there because the antigen load is still there.
So my question exactly now, it's the scoliosis, dead or alive, are equally antigenic?
Yes,
They are.
When they're dead, they're less
Yes.
or more?
same.
That's-
It's
They're
antigen.
equally antigenic.
So you wouldn't really expect the anaphylaxis rate to change at all by giving pre-operative
Perhaps-
antiemetic therapy.
If it ruptures, it does not make any difference.
Right.
Correct.
The worst thing that could happen is for this to rupture during surgery.
Oh,
And
absolutely.
that's what makes what you do so
That's the fear factor.
so admirable to get any kind of cyst out and what Taman Farid does. And so mainly the aim of therapy is to prevent future daughter cysts if there's a spill. But the anaphylaxis decreases a bit, but still very high.
That's very important is the fact that probably if you sterilize the cyst, if the cyst rupture either doing it percutaneously or surgically, that those actually pathogens that are spreading into the peritoneum or whatever, they will not contaminate the rest of the area. So you will not have
Correct.
1,000 hydatid cysts in the acid.
Absolutely.
Listed there.
That's the major
Problem.
point of therapy.
Yes, not the risk of anaphylaxis, which is the same.
Yes.
Okay, my call upon Dr. Mufassal to tell us about the histology of things. There's a question there before Dr. Hassan. Dr. Junaid.
I just want to say that with respect to dogs, these stray dogs, I was in Machu Picchu in Peru, and the inhabitants were around 30,000, and the stray dogs were 60,000.
Oh my God.
And there was no mention about hydatid cyst there.
Yes.
And I also want to make a comment about the use of albendazole. I thought the albendazole was more useful or gives you better results if the lungs are involved rather than the liver, because of the very, very small membrane there in the lungs rather than in the liver. I would also give you one bad or good experience of mine back in the early 1980s, when there was no CT scan or ultrasound, and I had a Saudi who had a very, very big mass in the liver, and all the time we had only radioisotopes. And so I elected to do the radioisotope and then biopsy. But then what happened is that radioisotopes did not come up with the results. So I was in the operating theater trying to do a liver biopsy with a Mangini needle at that time, which is a 16 gauge. And the minute I went in, I could feel the pop.
Yes.
And then I froze.
Right. You know what was
And
going
then,
next.
and then I pulled the needle very fast. And the patient was still breathing.
Oh, good.
He was breathing and breathing, and did well after that. And I told him, no, you go to Saudi Arabia and operate for your hydatid cyst.
Yes.
2 years later, he came to me and said, yes, I went and had an operation, everything. Everything was fine, but I felt the pop
Right.
when you go in. It was a 16 gauge needle, and that was a big biopsy needle.
And you gave him an epinephrine with the pump?
I'm sorry?
You gave him an epinephrine with the pump?
Well, I didn't give him anything.
You didn't give him anything.
I didn't give him anything. I just froze first, and then I pulled out my needle, and that's it.
You are filled with epinephrine.
Yes.
You are exuding. So albendazole works equally well, just equally well in the lungs and liver. Thank you.
Okay.
Just to make the discussion on the other side, I mean, I was a medical student. Also, many people, many of our mentors, they make us afraid of really anaphylactic shock of Hydatid cyst. But in my experience, I think it is much overrated than it's actual. I personally did more than 20 cases of aspiration, fine aspiration of Hydatid cyst, and nothing happened with them. And Dr. Junaid, you mentioned this case, and I think we presented one case at the GI conference where I aspirated the Hydatid cyst, and the patient given albendazole, and he improved dramatically, and nothing happened with him. And this not only my experience, and then I went into literature, and I found some people who did fine needle on Hydatid cyst, and they said that it's really overrated, the chance of anaphylactic shock. So I don't want you to go with the idea that Hydatid cyst is so common to get. It's actually very rare. I have done 20 cases, some of them published in the YouTube, and the patient did nothing happened to them. So it's not really something that you should really very much alert with them or be afraid or be dangerous, because our actual experience and experience of others, yes, you can do it and there's nothing danger. Although there are some cases, but it didn't, I reviewed the literature actually, very, very, very rarely happen with a fine needle aspiration.
You should be prepared with everything.
Yeah, but sometimes the patient was referred to us not because they are suspected Hydatid cyst. We found it in the histology. So it is not really actually so dangerous. I don't want you to go with the idea that it's so dangerous to do fine needle aspiration. No, it is not dangerous. Not my experience alone, but others' experience, and I have reviewed extensive the literature on this idea. It's not really so dangerous.
One is only one case away. You're only one case away of changing your mind. So
no, it's not me. It's not me only. I reviewed the literature on that.
you get one case of
fine needle aspiration, and I have reviewed extensive the literature because we have discussed this in the GI meeting. You remember, Dr. Junaid, we presented one case about it, and we have this discussion, and I reviewed the literature extensively. You go and review literature, and you see that people do not agree on this all the way. Anyhow, in this case, let's go. This is the Hydatid cyst that we received lately, and you can see it's really very good round shape Hydatid cyst, and it's actually floating on the. This is formalin, so it's less thick than formalin. And see how it's glistening. The surface is very smooth. This is taken, Dr. Ibrahim Speh took it from brain of one patient, and you can see the size of it. And it's almost transparent. I want to show you this video. When I rupture it, I really took picture of its rupture. What's up?
You removed it, but not without completely, without
and it's very interesting to see really something that probably you don't see much. I'm rupturing it. See how the fluid is coming, and this is clear fluid coming out of it, and it is slightly like a sticky fluid. You feel it in sticky fluid, but it is clear, and this is what you get when it's not infected. And this is different from the one that we usually in the liver. See the wall, how it is thin. Usually the liver ones, when I received it, most of the time they have really thick wall, not the brain tissue, which usually does not form fibrosis. This is typical histology. These are the scoliosis, and these are the hooks. These are the parasites, because you can see the hooks in them, probably in some higher power. These are all different scoliosis size, and these are the hooks. You can see them. And this sometimes be very helpful. This sometimes not all what you see in fine needle aspiration material, the hooks, they are very, very typical. And all the cases that I have done, 20 cases, most of these cases I diagnose them by the hooks. You see them by fine needle aspiration cytology, and they are very, very good clue that this is, and it is diagnostic, pathognomonic when it's there. You can see more of the scoliosis. I took more. See, these are the hooks that usually spread inside the fluid. A lot of the things that you see in the fluid are from the hooks. The scoliosis are not common. Again, you can see the hooks there in these spaces. الخوالب بتاعتهم اللي attach them to the wall. You can see different areas. Again, you can see these are the hooks and this is the scoliosis. The hooks are present on the periphery on the scoliosis. The third one, we can diagnose echinococcus by histology by either scoliosis or hooks, which are the most common, or laminated bodies. This is the laminated bodies. بيشبهوا كثير زحل حلقات زحل. You can see them how they are laminated bodies. This is the outer layer, actually biomaterial attached to them. This is biomaterial attached to them, but you can see these are مثل حلقات زحل, typical. And when you go higher power, I will show you. This is زي ما حكينا حلقات زحل, Saturn's rings, and these are the biomaterial attached to the periphery. You can see this is what you go, like when you go into حلقات زحل, you can see these are dirty material. بس كل واحدة ماشيين بحلقات. You give you an impression that this is what we call laminated bodies. You can see them very beautiful. And when you see this, it's not pathognomonic, but it is diagnostic of hydatid cyst. So these are the three really histology things. This is the biomaterial that usually when not, as I said, in the brain usually is not, you don't see gliosis, but the biomaterial attach itself to the outer surface of this material of the cyst. As you could see here, these are from meningeal cells. These are from the laminated bodies. And this biomaterial is cytokeratin 5/6 positive and epithelial membrane antigen positive. These are laminated bodies. And low molecular weight cytokeratin positive. So these are the features of hydatid cyst.
So which are the organs in our bodies that are affected by hydatid? Any anatomical site from head to toe. Liver is the commonest, 75, lung follows, 15%, central nervous system, brain and spinal cord, bones, long bones, and others, including kidney, breast, thyroid, spleen, breast, heart, and others. Orbit, hydatid cyst in the orbit. And the orbit from Iran, parotid gland. These are papers published. Hydatid cyst of the internal acoustic canal, internal auditory meatus, petrous bone. Involving the skull. You may think this is hemangioma, you may think of other skull lesions. Can be extradural, like this extradural cyst. Here it can be in the infratemporal fossa, extradural, epidural, again extradural from Turkey, and it can affect the brain. Now in the brain it's rare, it's 0.5% of all masses, but in endemic countries it's higher, 3%. The thing that break your heart, that 50–70% are seen in children. This is extradural posterior fossa. Again, extradural posterior fossa. You can actually misdiagnose these lesions easily. Subdural, extradural and subdural. This is subdural cyst. This is inside the brain in children. From Tunisia and North Africa is also an endemic area. It's in the brain. Again, in the brain, primary hydatid from India, from Turkey. And look at these unusual sites in the interhemispheric area or inside the ventricle. And these are the most dangerous, because if they rupture, death is a must. From Lebanon,
Can they rupture spontaneously in this location?
yes, can rupture during sport, spontaneously, surgical intervention, trauma, whatever. This is a very interesting paper from Lebanon, and it was published in 2005 in the epic of the Lebanese war by Dr. Fuad Haddad and his son, George Haddad. Fuad Haddad is a very senior neurosurgeon. In fact, he's one of the 3 neurosurgeons there were in the Middle East in the 50s and the 60s. Fuad Haddad, one of them, Anton Tarazi, here in Palestine and Jordan. Yes, and Rashid Jum'a from Pakistan. So to have a paper from Lebanon in this period is to be respected. Another one from Syria, and this is new. I think it's 20. Yes, recent, again, in the epic of the Syrian war, still they are publishing. We in Jordan, we don't like publication. Yes, it's not important. From India, 2007, look at this site. It's in the brainstem. Now that is a different kettle of fish. How to diagnose, how to approach, and what to do. You cannot use the usual surgical methods here. You go for aspiration and putting some chlorhexidine, and then try to take the capsule out. This is the, actually, there is a paper about this, and I'm going to show you that to you. Again, brainstem, Hydatid. Again, this is from Syria this year, January this year. Again, amazing that they are publishing. From Saudi Arabia, this pre-Pontine thing. It did not end in a good way, but they tried their best there. Again, another brainstem. Yes.
With these ones you showed us, all these people who had the cyst in other locations as well, or they're purely in the brain?
Most of them, they had it and somewhere else, but a few of them, they had it just only in the brain, which is amazing.
How few? 5, 10%?
In my series, I had one case, a brain without anything.
In the literature, 10 to 30%.
Yes.
Thank you. 10 to 30.
Now, coming to the spine, again, it's rare, but again, the spine here is difficult to treat. Difficult to treat in the sense that it is considered as a palliative treatment. There is high recurrence rate and high mortality and morbidity. Look at these lesions. They could be extradural, they could be intradural, extramedullary, they could be intramedullary. Again, you can see these are actual cases. Odontoid process. Thoracic spine. Again, here thoracic spine. Treated with, of course, to put a foreign material like fixation in something like this is something controversial. Again, Hydatid cyst in the thoracic spine and the sacrum. From that is destructive, absolutely. That's why you need fixation. Sacrum completely destroyed from Tunisia. And here in this case, because it was so destructive and they could not excise it, they actually put a drain and kept that for drainage and injection of materials there.
Now, if such cases are treated medically, can you avoid fixation when there is such
No,
destruction of the spine?
No. You have to think of Hydatid in the brain and spine completely different than in other parts of the body.
That's why I'm asking.
Yeah, it's totally different story. So we do not like in the brain at all aspiration. It's forbidden.
No, I was talking about medical treatment.
Yes,
Not aspiration.
sure. Heart, it likes the left ventricle, but it could be anywhere. Again, you can see there, brain and heart. From Croatia, again, left ventricle, this is the heart being opened. And the lungs, pulmonary. Remember, 15% of them affect the lung. Liver is 75%. Look at this here. Kidneys. And renal hydatitis is presenting with hydaturia in the urine, passing some of these cholecysts and cysts. urinary bladder, omentum, long bones, from Iran, again, long bones, soft tissue, muscles, soft tissue in the neck, soft tissue again in the vastus medialis. What about radiology of these lesions? There is typical radiology and atypical radiology. The worrisome is the atypical ones. And people would say, why should I know? You must know, because if you want to deal with these cases, you have to keep your mind open. Rounded, well-defined. Not all of them are rounded and well-defined. Unilocular, they can be multilocular. Contents of low density like that of the CSF, sometimes they are not. T1 hyperintense, T2 hyperintense, sometimes they are not. This is typical radiology, rounded, well-defined, it looks like CSF, etc. This is typical radiology. Sometimes you can see actually the capsule. You can see the sand. The scholus is precipitating in the bottom. They don't usually take contrast. There are cases reported with contrast. And what would you diagnose here? You diagnose abscess, you diagnose a glioma, you diagnose TB, whatever. Calcification is very rare, but it can happen. Reported calcified cysts, calcified cyst, look at this. So you have to worry about the uncommon cases. Primary calcified. Would you ever think of this as Hydatid cyst? Not the shape, not the color, not anything. Tunisia, again, unusual brain edema. Usually they are not associated with brain edema. Here are some cases which were associated with brain edema. They can be single cyst or could be having daughter cyst inside. So daughter cyst. Single cyst with some daughter cysts. Or multilocular like this. Multilocular, you can see the loculations. Multiple cysts, not one, but multiple. Again, here multiple intracranial Hydatid cyst in a boy. Multiple cysts. Disseminated, meaning that it is in multiple organs. Again, look at this. If anyone can think of this as Hydatid, he should be given the status of United States president.
This is
Multilocular. Infected, they can get infected. So again here, infected. Presenting as cerebral metastasis, mass, just like any brain tumor. Alveolar, again presenting very unusual, like a tumor. So what's the differential diagnosis? Should we be afraid? Yes. My message to you, be afraid. Think of echinococcus cysts, because you will face trouble if you don't. Arachnoid cyst. Porencephalic cyst after trauma or surgical treatment. Megaloencephalic leukodystrophy, subcortical cysts. Epidermoid cysts. Dermoid cysts. Choroid fissure cysts. Ependymal cyst, inside the ventricle. Choroid fissure cyst, as we mentioned. Choroid plexus cyst. Parenchymal cyst from the parenchyma. Neuroglial cysts. Neuroepithelial neuroglial cyst again. Enterogenous cyst, one of my patients, Iraqi patient, with this. enlarged perivascular spaces, which is very unusual, but you can face it. Abscess, bacterial, non-bacterial, neurosurgery, especially if multiple tumors, hemangioblastoma, cyst. Sometimes you don't see the nodule, so you go and try to take it out and it ruptures, and the patient will die on the table or die later on out of metastasis of these cysts. Pilocytic astrocytoma, oh, a cyst with a small nodule. Yes, but this could be part of the capsule of hydatid cysts. Metastasis. So be careful. So once a cystic lesion is found, hydatid must be considered in countries where it is endemic. Before I give you the microphone, ask my colleagues, the radiologists, how they feel, please.
Thank you. So first of all, it depends the imaging findings on the type of the echinococcus. The granulosis types usually typically single large cyst. It comes in children, and there is no calcification, no edema, no enhancements unless it is complicated. The difficult one is the alveolar type. This is the one which is the nightmare for the large differential, which Dr. Ibrahim said. It came more in adults. It has calcification more. It has soft tissue enhancement, nodular or peripheral, and it can be confused as a tumor. It can be multiple small cystic lesion or solid lesion throughout the whole brain, and it is very difficult. Usually, but I want to remember you that the hydatid is the second most common parasite for the brain after the cysticercosis. So it is not in our area. You have to think it when you see it. Okay. The treatment, Dr. Ibrahim, he covered it, but I want you to remember always that if it becomes enhancing or there is edema, sometimes maybe it is complicated. Okay. Diffusion restriction, you can't see diffusion restrictions on the MRI. And if you see enhancement, it is multiple. You have to think of alveolar stuff. Thank you.
Thank you. So, Daniel, would you like to comment?
Excuse me. Thank you, Dr. Ibrahim. But the hydatid cyst, from a radiology point of view, there are two types. There are two types. One is the typical. We have the cyst as we saw without any calcification, or even if there is a calcification, it's about 1%. There's no edema, there is no wall enhancement. Atypical one is sometimes it has wall enhancement and it has edema. I think it's not edema, it's leaky. This is some leak of the cyst, and it indicates an ongoing inflammation rather than other thing is. A differential diagnosis of typical, there are three main things. One is hydatid cyst intraparenchymal. The second one is neuroepithelial cyst. The first, the most important thing is to go to the flare. If there is any gliosis, you have to go to other category. If there is no gliosis, they are three differential diagnosis, not more. Now, if there is an enhancement, there is a lot of differential diagnosis. The most important thing is abscess. But if you have to go to diffusion, abscess has restricted diffusion, but the hydatid cyst does not. Second one, metastasis. If you look for metastasis, first of all, metastasis has a regular wall, has nodule in the wall. If you go to spectroscopy, it has very high lactate. But if you go to spectroscopy for hydatid cyst, if you have amino acid, you have alanine, you have lactate, you have acetate. Also, you have the most important thing is pyruvate, which can be found in 2.4 ppm. The third thing is, as Dr. Ibrahim said, is high-grade tumor. But almost the high-grade tumor has a soft tissue nodule. You should have a soft tissue nodule. And if you go to the spectroscopy, also all these tumor has choline and have low NAA, but Hydatid cyst does not have choline at all.
Taking this further, I mean, how much can you help the neurologist or the neurosurgeon in making a diagnosis of the Hydatid cyst? And how much with the modern technology now, with
Yes.
PET scan, functional imaging, and so on and so on, how close can you come to a definitive diagnosis, or at least
To know your differential diagnosis.
It is crucial for any
Yes.
surgeon who wants to attack something like this.
Uh,
More certain than not.
I said before, if the cyst is a typical one, you have to go to a spectroscopy. Now, spectroscopy, as I said before, there is an alanine, there is an lactate, acetate,
Acetylcholine.
amino acids, and has the most important thing is pyruvate. I think knows that is pyruvate is very important, is found only in Hydatid cyst in 2.4 ppm in spectroscopy. If you go to Hydatid cyst, we have just only lactate. If you go to the neuroepithelial cyst, it has choline because it's a neural cyst, but the others has no choline. I can know my differential diagnosis in addition to conventional T1, T2 FLAIR sequence, because there is no gliosis, and also diffusion. It can help. If it's typical, it's an atypical now, this is my problem, but I have to go to spectroscopy also. I can differentiate between Hydatid cyst and high glioma by choline and acetate. It has acetate and choline, but Hydatid cyst does not have also one amino acid. Metastasis has very high lactate only.
So
Only lactate.
my conclusion is that you can be to a higher degree to say this is a Hydatid cyst rather than anything else.
Yes.
You can say the most likely diagnosis is a Hydatid
If
cyst.
I go to
from the
spectroscopy and sometimes perfusion can help a lot.
What about low-grade glioma as opposed to high-grade glioma? And placentic astrocytoma, for example,
Yes.
is a perfect example of a low-grade glioma that might graded.
Does not enhance and has choline. Has choline and AA. But Hydatid cyst does not have.
Right.
Okay.
What I wanted to say is this before I give the microphone, is that radiologists can help if they want to, if they really go deep into discussions. But most of the reports are flimsy 3 lines, always the same. No aneurysms, no AVMs, no shift of ventricular system, parenchyma is okay. That's the reports we receive because they report in the MRI as well as the chest X-ray and the femur X-ray. They are not neuroregulars.
I'm going to skip the anatomical cysts and just fixate on one important slide, apart from the importance of not missing an abscess. And we discussed the parasitic astrocytoma differential. But again, from spectroscopy to very low tech, for the love of God, nobody should be put on the table without being examined properly. Mets can easily be ruled out or ruled in by a good, thorough physical examination. And I know that I'm preaching to the choir here, but we have a whole generation of new so-called medical students who have no idea how to examine patients, thorough or otherwise. They simply are built into the culture that, oh, no, you just check for radiology reports and nobody bothers to examine patients. A lot of Mets, not all of them though, a lot of Mets you can detect a primary on a thorough physical examination. Putting a female patient on the neurosurgical table because nobody bothered to detect the 3 by 3 centimeter breast mass is criminal, to say the least. And these Mets do happen, and we see them every day, not every week, and we preach against this every day, not every week. Not to mention the abscess issue that can easily be missed because nobody bothered to look into the teeth, nobody bothered to look at the oral hygiene, etc.
Thank you. Farid Adam, do you have anything to add from the radiology point of view?
No, thank you.
Okay. So again, this is the golden statement. Once you have a cystic lesion, and if you are in an endemic area like ours, think of Hydatid disease. What are the manifestations of these? Of course, it's basically a benign lesion, so increased intracranial pressure, headache, motor weakness, vomiting, mental change, visual change, epilepsy, coma, or changes in speech. And for this, I'd like to ask Dr. Maurice Dahdaleh, senior neurologist, graduate of University of London, ex-chairman of the Jordan Neuroscience Society, to speak about speech changes. It's there. I know.
I'm not prepared for this. I can give you just a few, just make a short comment, okay?
Oh, you put some slides. Oh, that's very good. Yes. Okay, that's great. Now, I think many of you who've been at medical school have been taught, we've been teaching about speech for the last century using the famous Wernicke-Lichtenstein model of speech, which is the basic speech of expressive dysphasia, receptive dysphasia, and conductive dysphasia. And we always thought that it was as simple as that. It was simple. And the way that people found out about where these areas lie is from the anatomy and the lesions that people in the past looked at when they did postmortems on the brain, and they found out which area is looking after expressive speech and receptive speech, etc. And then they have been divided into Broca's area, which is the area in the frontal lobe, which is responsible for expressive speech, Wernicke's area, which is receptive speech, and then there is no normal area, and also there's the conductive speech, which is basically when somebody speaks, you hear his sound. This goes to the auditory cortex, which is in the temporal lobe, and near there is the Wernicke's area. There is Wernicke's area, which decodes the sound and interprets it, and then either you store it, or if you want to speak, you send it down the line through the conduction between that area to Broca's area. From Broca's area, the speech center, if you remember your anatomy, it's upside down, and what you do is you where is it? Here? Sorry. Oh, this one. Okay. So basically, from the speech area is very near to the motor area, which is looking after your mouth and the speech area, the tongue and the voice and so on. So it's a very well designed brain where you can easily, from the brain, if you want to speak, you can send the message to the area which is very near, and then you can speak. But in the last, how do we go forward from here? So it all looks very simple. I think it's very important that in the last 30 years, with the advent of MRI, functional imaging, magnetoencephalography, and PET scanning, and also the improvement in our understanding by using psychological tests, we have been able to identify that speech really is not that simple. It's really is very complicated, and it doesn't just involve these areas. It involves both sides of the brain, and it involves many other structures in the brain, for example, like the parietal area, the occipital area, and also deep structures like the thalamus. So basically, the process of speech is a complicated one, and it's not as simple as we all studied it at medical school. So it's very complicated. And that is very important. Why? Because when the surgeon comes in, he has to know the anatomy pretty well and to know how to approach any lesion which lies in that area. And obviously, any wrong move, any wrong incision can actually cause quite severe damage and permanent damage to the area
responsible for speech. So basically, it is very important. So if you have a lesion in that area, you have to be lucky to get it in an area which is not an eloquent area of the brain, which is responsible for a vital function. And also you need a very good surgeon who knows his anatomy very well. And when he goes in, he actually pretty much knows exactly which area to avoid and how to go for that lesion. And that is the important bit. So in the last 30 years, and we're getting better and better at understanding the areas in the brain, the function of the brain responsible for speech. But it's really more complicated. This is my message I want to put forward than it really we understood when we were at medical school. No, thank you. Thank you.
So basically, Broca's area is in the frontal operculum here, near the motor area of the face and arm. The posterior part of the superior-temporal gyrus is where Wernicke area is where the auditory area, and in the angular gyrus is the nominal dysphagia, where patients cannot tell you the name of objects. So you show them a pen, what is this? You would say, this is what they write with. What's the name of this? This is they write with, and so on and so forth. The glasses, this is what they used to see with, and so on. So Broca's is the motor dysphagia, Wernicke is the receptor dysphagia, and angular gyrus is the nominal dysphagia. Now, why are we putting this? Because it has something to do with the video that I'm going to show you. So what's the treatment? As I said, the first and foremost for the brain is surgery. You don't want to waste time giving medications with anything in the brain, small or large. And your aim is to remove it without rupture. If it ruptures, it's ruptured into the subarachnoid space, it will go to the CSF. Either the patient will die on table from anaphylactic shock, or later on, within 3 months, due to multiple hydatid cysts everywhere. If you can't, then, like in the brainstem, then you aspirate and remove. That's what's called Bayer technique. Puncture, aspirate, irrigate, resect. We don't use this in the brain unless we cannot. So this is just a palliative thing. If you have multiple cysts, then you target the largest one, or you do it in stage surgery. Or sometimes you will continuous drainage of cysts like we have seen in the spinal mode. Surgery of hydatid cysts of the brain is extremely difficult. Why? Usually you have large size. The wall is very, very thin. They are adherent to the ura. You have to pass it through the normal brain. There are adhesions around the cyst. If it is close to the ventricle, it's horrifying. And as you're doing the surgery, it may rupture, and the patient may die or develop meningitis or neurological deficits. This paper from Turkey, 2000, 330 patients, cranial, 207 excised without rupture, 86 ruptured. This is a very good center, very famous center. Mortality, 10%. So this is a serious disease. So what to do? How to position your patient on the table beforehand. Once the anesthesia is done, then you have as a surgeon to look over how the patient is put so that you can use the gravity effect during surgery. So if the tumor is here or the cyst is here, you try to put the patient this way so that it would fall down. And then if you want to change position more, then you have to have loose draping so that you will not stretch the draping. You have to have large bone flap and large dura flap. How large? It has to be 2 to 3/4 of the diameter of the cyst. So the bone flap should be large, the dura flap large, so that when the cyst comes out, it is not deformed by the edge of the bone or the dura. Yes, yes, because if it is deformed, it will rupture. And you have to have careful landing, avoiding cautery, lowering the head of the patient, rotating the table, gravity effect, and then the hydrostatic pressure effect. How do we do surgery? By something called Dowling technique. And who is Doling? Ernesto Doling from Argentina, 1929. He described this: injecting saline between the cyst and the brain. And then this is the Doling technique. As I said, large flap and all these things that we mentioned. And then there was an adjustment on the technique called modified Doling technique, and that occurred in 1975. But people from Latin America, from Uruguay. And in this way, I remember the stray dogs, 60,000 and the population of 70,000 in Peru, right, Dr. Janid? 54, again, this is modification. So sometimes they inject saline into the opposite ventricle to push it out. But look at the opening of the bone is larger than the diameter of the cyst. Recurrence is high, and it is very dangerous. It can recur in 30%. If you don't,
Rupture?
with rupture. Oh, yes, of course. The time of the recurrence is maximally within 1 year. This is, again, we put it in the previous ones, but these are some of the cases of multilocularitis group. They can be in the Pioneer region here. My personal experience with these, I have 6 cranial hydatid cysts and 2 spinal hydatid cysts. I could recover one of them. The other one, I could not find the x-rays and so on. This, one patient of mine, is considered to be one of the largest hydatid cysts in the world. So in the brain, it's rare, and it is a serious problem. Let's see some of the cases. 7-year-old patient from Iraq. Look at this huge cyst.
So you didn't have any symptoms or anything? This big?
That's the medicine in the report. Unless the patient dies, he is okay.
That was.
I will show you. I'll show you. So these are still pictures, still pictures. As you can see, if I go back, it's close to the surface. This is a good thing and not a good thing, because sometimes it's adherent to the dura.
Is that a child?
A child, 7-year-old from Iraq, who used to play with the sheep and dogs and so on. And some of you mentioned that it is transmitted from dogs to human, can be transmitted directly from sheep to human. Especially if Eid al-Adha, you go and you catch the sheep and see if it's good or not, and you do this. So you catch it, put it in your mouth, and leave. So this is how we are separating the dura of the cyst, and then injecting to get it out. Let's see the movie.
Listen, can you get a Kubiniye? Not to my knowledge.
There was one report that it could be transmitted by wind and from Libya.
Yes.
The southern part of Libya, they had hydatid cysts when they didn't have any dogs and all that.
True.
And there's some wind factor
You see,
there.
some camels can also.
Camels, foxes, and all kinds. So this is the separation of the dura from the cyst, which is on the surface, which is good. But again here, yeah, there's some adhesions. And this is the time when it ruptures. So very, very thin brain here. You can see the capsule of the cyst. So thin that you can see the inside of it. So transparent.
How old is this patient?
7. So we are separating the dura. Again, here your heart stops several times, because every time you do something, you think it's going to rupture.
How long did it take you? How long was the surgery?
About 4 hours. So here you are. Presenting. This is very atrophic brain on top of it. You separate it, and your aim is to find the good plane of cleavage between the so-called the capsule of the brain, the gliosis, and the true capsule of the hydatid cyst. And once you do that, you inject saline. The saline could be hypertonic saline 3% or normal saline, but again, look how transparent it is. Inside are daughter cysts. This one contained by volume contained 200 million parasite. 200 million. Imagine if it ruptures, what it's going to cause. So I'm finding the good plane of cleavage, injecting saline, putting the patient with the gravity, adjusting the table.
What are you injecting here now?
Saline.
This is just to facilitate
It's
your
hydrostatic
dissection.
pressure so that it will separate the adhesions between the cyst and the brain.
Yes, yes.
And this is held by gravity and by positioning of the patient. No. So that's it. Okay. That's the cavity of the systems. And that's the boy afterwards. And that's the cyst. 12 centimeters by 11 centimeters by 9 centimeters. And I took an orange in the theater. This is my hand. This is the size of my hand. This is the orange, and look at the cyst. Yes, it is woman. Second patient with this. No, this is the same patient, sorry. This is a pre-op and post-op. Pre-op and post-op. Pre and post. Second patient, 56-year-old male patient with this lesion. Now, the problem with this lesion is that it is in the dominant hemisphere. He's right-handed. It is in the area of Broca's area, Wernicke's area, and angular gyrus nominal dysphagia area. You can see the Sylvian fissure. This is a good example here. This is the beginning of the Sylvian fissure. So Broca's is just here. Here.
Did he have any speech problem?
Yes, he had. He had actually receptive, expressive, and nominal.
That's how he presented.
That's how he presented. So you can see that the stereotemporal is also. So Wernicke is here, Broca's is here, nominal is here. Now that's a dilemma for me, because ideally the cortical incision should be in the middle so that it will not be deformed. But if I do it in the middle, then I will affect all these structures.
So then did you do functional MRI?
No. You can see the middle cerebral artery is elevated. Most of the radiologists report this as normal. They don't think of displacement of vessels as abnormality. They are looking for two things, as if the whole vascular pathology is limited to aneurysms and AVMs. So when I see no aneurysm, no AVM, I really feel sick in my heart, because this is not the way it should be. No, very few radiologists will report that the middle cerebral is really elevated. Look at it. Chest X-ray was normal. There's a cyst in the liver confirming that this is.
Are you saying that the radiologist reported this, didn't mention that?
Yes. 99 of cases did that.
And you knew this was there was a mass in the time?
Yes. I use navigation. She hadn't had them in navigation. Hamza from Master Ziyad Saleh was with us. Again, here I'm trying to find exactly, because this is a serious business. I don't want to just save this patient's life and then giving him permanent dysphagia or permanent neurological deficits. So I'd like to know exactly what I am. So we use navigation. Again, I put this picture. This is Broca's, this is Wernicke. This is Sylvian fissure. And again, if I do this incision here, I will catch Broca's and Wernicke. If I go in the posterior, in the superior temporal gyrus, I'll get Wernicke. So I had really to, I did not sleep that night, thinking of how would I approach this. So if I do this here, it's dangerous. If I do it here, it's dangerous. Ideally, I should put it here because it's in the middle, so that the cyst would come out without any deformation. If I put the incision here, I'm aware of the important structures, but then the cyst has to go sort of sideways to go out. As if you want to get me out of this door, you get me out of that door, so I'm deformed. So this is the finding, doing the cortical incision and injecting and getting it out. Let's see the surgery.
Where did you go? Your incision was?
And I will see it again. So this is top here, this is below, bottom, anterior, posterior. This is the temporal lobe, this is the Selbian fissure. If I do the incision here, I'll catch a Broca's and angular gyrus. If I do it here, I will catch Wernicke. So I opted to go this way and then squeeze my way this way.
That's the cyst right there. Right?
Yes. You have to do cortical incision by about 1 or 2, 1.5 centimeters. So you have to know, yeah, now we are injecting the saline. At the same time I'm injecting the saline, I have 3%, 25% or 50% saline packs, so that if it ruptures, I'll put it immediately. Again, see how transparent it is.
This is normal saline, the one that you use.
This is normal saline. I only use the hypertonic if it ruptures. This would help take the adhesions away. With the effect of gravity, then starts coming out. Again, how you position your patient from the beginning. How to adjust the table is all important.
Wow. That's cool.
And this is the site of the incision. You can see Broca's is here, Wernicke is here. This is the cavity. Okay. So lots of mental process should go into that. This is immediate post-op the following day, showing complete accession of the cyst with no complications. And this is the patient himself. With this, I finish and I thank you.
Thank you. It's a special room.
Yes. Any questions? Please.
About this child, 7 years old.
7-year-old.
After removing the cyst, the space where the
Yes, the brain will expand. Sometimes what we do is to put a Foley's catheter or Fogarty catheter, put it into the cavity, inflate it so that it will take the cortex out, and then remove it after 3 days. Any questions, comments? If not, thank you. We'll see you next week. Thank you.
Very well done.
Hey, Abdullah, are you there? Abdullah? Oh, good, you're there. Great. How you doing? Okay, I think Dr. Sabeh is coming, okay? Dr. Abdullah, so you can ask questions, okay?
People.
Hello, sir.
Hello. It'll just be a second until Dr. Sabeh comes, okay? Hang in there.
I'm fine.
We'll talk later.
All right.
Okay. A little noisy there.
I don't think all neurosurgeons will do that.
Greetings, Dr. Sabeh.
Hello.
Yeah, greetings from Miami Beach. John Bennett from Neurosurgical TV. Thank you for another excellent multidisciplinary presentation. And I was telling people you don't see that many on the internet. But I'd like to introduce you. I think you met Abdullah last week, a neurosurgeon from Nigeria. Welcome, Abdullah.
Thank you so much, John. Thank you, Prof, for that fantastic, wonderful, multidisciplinary presentation. I really gained a lot from that. My only question is that after the fantastic removal of the cyst, do you follow it up with medical treatment as well, and for how long?
Yes, I do. Yes, we do. Yes, from 3 weeks to 6 weeks.
Oh, okay. All right. Thank you. Thank you so much.
Because although you have removed it without rupture, you are want to give the best chance for the patient, especially that there is a liver hydatid cyst in addition that has to be removed.
It's okay.
Okay, we won't keep you long, Dr. Sabay. It's kind of noisy in the background. Do you have a topic for next week yet?
Yes, I thought about it, but I will finalize it by tomorrow.
Okay, very good. Okay, we'll see you next week, and thank you very much.
Thank you. It's my pleasure. Thank you. Bye-bye.
Thank you so much. All right.
Okay. Well, I can stop that recording. Okay, how you been, Abdullah?
I'm good. I'm doing fine. I'm okay.
I'm sorry? Okay, it's kind of noisy there. What'd you say?
I say I'm doing fine. I'm okay. I'm good here in Morocco.
Oh, good. Good. Yeah. I'm getting busy because we're televising a conference on the coronavirus from London on Monday. Let me show you. I don't know. It affects everybody. I mean, the way things are closing and conferences are being canceled, it affects everybody.
That's right.
Let me screen share and get a hold of what I'm doing here. Okay, a little confused here. Sure. Okay. Let me screen share. Okay, this is going to take place Monday. It's an all-day thing. They have a bunch of speakers, mHealth, live. I'm speaking on live streaming. So some other people from London and that area, mostly about mobile health. I don't know if that interests you at all, but I'm interested in all of it. I love to televise it all. You know,
it's nice. It's okay. It's nice.
Well, you know, it's because I'm like a intern in video production.
No.
Video. Yeah. No, video. How to show, how to make the shows, how to get the people, how
the angle. Okay. Yeah.
Yeah, how to promote, how to televise. So.
So your interest.
Yeah. So what? You're a general neurosurgeon in Lagos, right?
In northern Nigeria, not in Lagos. Not Lagos in the southern Nigeria.
Oh,
in the northern Nigeria, close to the capital, Abuja.
Oh, okay. Is it going okay now?
It's very good. I'm good here. You know, I'm in Rabat now. I'm doing fellowship in stereo taxi and.
Are you in Morocco now?
Yes, I am in Morocco.
Oh, with Nuru.
Yes, Nuru though is in France now.
That's right. He's in tours, right?
Yes, that's right.
That's right. That's we've televised from there. There's a famous anatomy lab, as you probably know.
You say so, yeah.
So yeah, he's there now, and so anytime you want to present something. Matter of fact, Saturday, would you like to present for the young African neurosurgeons?
Not Saturday. I'll be busy. In fact, I won't be in Rabat on Saturday. I'll be going to Casablanca. But it can. I can present it anytime after that. Maybe it's the upcoming Saturday.
Okay, maybe the following Saturday.
That's right. Yeah.
Yeah.
I'll present on Gamma Knife.
That would be great. And please, you got my email address, right?
Yes.
Yeah, Abdullah, let me make sure. I think I have you. Are you on Facebook?
I'm on Facebook. I'm your friend on Facebook.
Okay. Let me make sure I got you here. Come to. Abdullah. Abdullah Jamo. Okay, there you go.
That's right.
Yep.
Yes,
Yeah. Okay.
Yes,
Yep.
yes.
Yeah. Okay.
All right.
Great. Okay. Okay, super. Okay, so next I'll just write a note here. And just so you won't forget. Rick, you on Gamma Knife.
That's right.
Great. Okay, I just wrote you a note, and I'll write Ulrich.
Okay.
Abdullah. Okay. Okay. Very good. Very good. Okay. So I'll let you go on with your day and enjoy your day in Morocco.
Thank you, and you too. Enjoy Miami.
Okay. Thank you. Bye bye.
Okay.